Welcome back to the deep dive. Today we're tackling two conditions that honestly cause a lot of anxiety in pediatrics. We're talking about acquired heart conditions.
Right. Specifically rheumatic fever and Kawasaki disease.
Mhm.
And, these are so important because they're not the structural defects a child is born with.
Exactly. These are inflammatory processes that well, they erupt in childhood and can cause serious permanent damage to the heart.
And that's our goal today, to give you a real masterclass based on your NCLEX prep material. We're focusing purely on high-yield clinical reasoning.
Our mission is pretty simple. We want to stop you from ever confusing these two conditions again. We're going to get into the why behind the pathology and the how of the management.
Yeah, and we're looking at it all through that lens of prioritization. What does the nurse absolutely have to do first? What's the critical long-term teaching?
So for today's agenda, we've structured it for retention. First, we'll get into the etiology and pathophysiology of each one, the root cause.
Then we'll spend a good amount of time on the hallmark signs and symptoms. So we'll apply the Jones criteria for rheumatic fever and break down the three phases of Kawasaki.
And finally, we'll get into management. We'll contrast the drug protocols, aspirin, IVH, all of that, and the really unique long-term plans.
So let's just dive right in.
Let's do it. What actually kicks off these inflammatory catastrophes?
Okay, so let's start with rheumatic fever.
When we talk about rheumatic fever, everything, and I mean everything, hinges on one single link. And that's group A beta hemolytic streptococcal pharyngitis. JABHS.
That's it. That EHS connection is probably the single most testable piece of information for RF etiology. It's an inflammatory disease that happens after an infection.
After. That's a key word.
A huge key. It's usually 2 to 3 weeks after a child has had strep throat or scarlet fever that was either not treated at all or not treated adequately.
So just to be clear, when rheumatic fever starts, the child isn't actively sick with strep anymore.
Not at all. The sore throat is long gone, and that's what can be so confusing.
Okay, so if the infection is gone, why does the body suddenly turn on itself weeks later? I think this is where that idea of molecular mimicry comes in.
That's the engine of the damage, exactly. So when the body fights off the strep bacteria, it makes these antibodies that are designed to attack proteins on the surface of the bacteria.
Right, standard immune response.
But here's the problem. Certain proteins in that JABHS bacteria look almost identical, structurally, to proteins we have in our own human heart muscle, our joints, and even our brain.
Wait, so the antibodies the body made to fight strep, they can't tell the difference between the bacteria and the body's own tissue.
That's molecular mimicry in a nutshell. The immune system's weapons mistake the body's own heart valves, for instance, for the strep bacteria, and they launch an autoimmune attack. It's friendly fire.
And that inflammation is systemic, it goes everywhere.
It does. It hits the joints, skin, brain. But the damage that really lasts, the permanent damage, is concentrated in the heart. And that collateral damage is why RF is so feared.
This brings up the nurse's role in prevention immediately, which is, a massive NCLEX theme.
It's the most high-yield prevention question you could possibly get. Since you can't get RF without having a strep infection first, the primary role is just aggressive screening and treatment.
So a kid comes in with a sore throat.
You make sure a throat culture gets done.
Right.
And if it's positive, you make sure that antibiotic treatment starts right away, and this is critical, that the full 10-day course is completed. That eradicates the JBHS and just stops the whole autoimmune cascade before it can even start.
And if that doesn't happen, if the attack does occur, we get the big life-altering complication, rheumatic heart disease or RHD.
RHD is the most common and frankly the most devastating long-term outcome of RF. The inflammation specifically goes after the endocardium and the heart valves.
So over time, that inflammation leads to scarring.
Exactly. It causes scarring and thickening of the valve leaflets, which severely messes with their function. They either get too stiff, that's stenosis, or they get leaky, which is regurgitation.
And are there specific valves that are more vulnerable?
Yes. The sources always point to the left-sided valves. The mitral valve in particular is the most commonly affected.
And damage to the mitral valve is a huge problem.
It's a huge problem. It disrupts blood flow from the left atrium to the left ventricle, which makes the heart have to work so much harder, and, well, it just sets the stage for chronic heart failure down the line.
So zooming out for NCLEX, the goal of all RF management is just immediate strep eradication to stop that valvular damage from ever happening.
That is the #1 goal, prevent RHD.
Okay, that's a very clear pathway. Now let's pivot, and pivot sharply, to Kawasaki disease. Because if RF has a clear bacterial trigger, KD is a lot murkier.
It is much more mysterious. KD is classified as an acute systemic vasculitis, And that word vasculitis is everything. It just means inflammation of the blood vessels.
And the cause is unknown.
The exact cause is still unknown, but the leading theory is that it's a hyperactive immune response to some kind of infectious trigger, probably a virus, in kids who are already genetically predisposed.
So it's not the antibody mistake we see in RF. It's just widespread, chaotic inflammation of the vessels themselves.
Precisely. It's a multi-system disease, and it causes this intense inflammation and damage to small and medium-sized blood vessels all over the body.
And is there a high-yield demographic we need to know?
Absolutely. You have to remember that 75% of cases are in children under 5 years old.
Okay.
So if you see a question about a very young child, a toddler, with a persistent, high, unexplained fever and signs of inflammation everywhere, you have to be thinking about KD.
So if RF attacks the valves, KD attacks the vessels, what's the ultimate danger from that vessel inflammation?
This is the other critical NCLEX differentiator. The pathology in KD is all about the coronary arteries. The inflammation makes the walls of those arteries incredibly weak,
Which leads to?
the most serious long-term complication, which is the formation of coronary artery aneurysms. These are spots where that weakened artery wall just balloons outward.
And an aneurysm creates two immediate life-threatening risks, right?
Yes. One, it could rupture, which would be catastrophic. But more commonly, the turbulent blood flow inside that aneurysm can cause a clot to form.
Which leads to a heart attack.
An acute myocardial infarction. A heart attack in a toddler. It's a terrifying thought. So you have to burn this link into your brain. Kawasaki disease equals coronary artery damage.
We should definitely talk about the MISC connection here. Multi-system inflammatory syndrome in children.
Yes, MISC is like a perfect clinical model for how we think KD works. Your sources define it as a Kawasaki-like disease that's associated with COVID-19.
So with the SARS-CoV-2 virus.
Right. And critically, it doesn't happen during the active COVID infection. It happens weeks later. It's a late post-viral immunological reaction.
Which just provides more evidence for that theory of a viral trigger causing this massive vasculitis that looks just like KD.
It's the same fundamental pathway, post-infectious systemic inflammation that just wreaks havoc on the vascular system.
Okay, let's just nail this down one more time before we move on. Rheumatic fever, post-strep, autoimmune attack on the valves leading to RHD.
Kawasaki disease, systemic vasculitis, damaging the coronary arteries, leading to aneurysms.
If you get those two concepts mixed up on the exam,
You will absolutely choose the wrong management strategy. You have to keep those two words, valves and vessels, completely separate in your mind.
All right, now for the really interesting part. Putting the clinical picture together. A test question isn't just going to hand you the diagnosis, it's going to give you symptoms. Let's start with rheumatic fever and the Jones criteria.
The Jones criteria is your diagnostic blueprint. You need evidence of a recent group A strep infection, like an elevated ASO titer, plus either 2 major manifestations or 1 major and 2 minor ones.
So let's break down those 5 major criteria. I remember the mnemonic Jones.
Perfect. So let's start with J, polyarthritis. Joints.
What does the nurse need to see here? What's the specific finding?
Polyarthritis means inflammation in multiple large joints. So the joints will be visibly swollen, they'll be hot, red, and very, very painful.
But the key detail, the thing that separates it from other types of arthritis.
Is that it's migratory. It moves. A nurse might document swelling in the child's knees one day, but the next day, the knees are better, and now the elbows or ankles are swollen. It literally changes joints every 1 to 2 days.
That migratory pattern is the key. If the joint pain is fixed in one place, you should be thinking of something else.
Exactly. And this is the symptom that usually responds really well to aspirin therapy. The inflammation and pain in the joints often calm down pretty quickly once salicylates are started.
Okay, next, O is for the heart. Carditis. This is the really dangerous one.
This is the big one. This is the source of all the long-term morbidity. Carditis is inflammation of all the layers of the heart pericardium, myocardium, endocardium. This is what becomes RHD.
So what's a hallmark sign the nurse would pick up on?
The classic finding is involvement of the heart muscle and the mitral valve. Often this presents as a new heart murmur that wasn't there before.
So if you're doing an assessment and you hear a new murmur or you see signs of heart failure.
That's the most ominous finding.
Yeah.
It requires immediate attention and continuous, close monitoring.
Got it. Moving on to end subcutaneous nodules.
These are little, firm, non-tender bumps. They're usually found over bony areas like the elbows, knees, or the back of the wrists. They're a sign of the systemic inflammation, but they don't cause any real problems and they go away on their own.
E is for erythema marginatum, the rash.
This is a really unique visual clue. It's a rash that doesn't itch, and it comes and goes, so it's transient. The description in your sources is perfect. Ring-shaped or like a UFO crop field.
A very specific look.
Very specific. It's usually on the trunk and the upper parts of the arms and legs, but, and this is important, it almost never appears on the face. If you see that rash described in a question stem, you have to think RF.
And finally, S. Sydenham's chorea, the neurological effect.
Right, the CNS involvement. This can show up weeks or even months after the strep infection. It's these involuntary, rapid, purposeless movements. It can affect the arms, legs, the trunk, even the facial muscles.
So it's basically the autoimmune attack affecting the brain.
It's an attack on the basal ganglia. And these movements can be really unsettling and emotionally distressing for the child and their family.
So for the nurse, what's the most important thing to know about managing it?
The key is that while it looks dramatic, Sydenham's chorea is transient. It can last for months, but it does resolve on its own without any specific treatment for the chorea itself.
So the nursing role is mainly supportive.
It's all supportive, keeping the child safe during these movements, helping manage the emotional side of it, and just educating the family that this is temporary and it will pass.
And we should probably just quickly mention the minor criteria.
Right. These are just the non-specific things like a fever, joint pain that isn't migratory, elevated inflammatory labs like ESR or CRP, and, of course, a previous history of RF. They just help support the diagnosis.
Okay, very clear. Now for Kawasaki disease. No Jones criteria here. Instead, its presentation is all about timing and phases.
Exactly. The 3 phases, acute, subacute, and convalescent, are everything. They tell you what to do and what to watch out for.
So let's break down phase 1, the acute phase.
This phase kicks off with a sudden high fever, and it lasts for 5 or more days. The critical thing is that this fever is completely unresponsive to the usual antipyretics, like Tylenol, and it's also unresponsive to antibiotics.
That unyielding fever in a young child is a massive red flag.
It's the biggest red flag. And along with that fever, you get the other classic signs. People often use the mnemonic crash and burn.
Where burn is the fever.
Burn is that high, persistent fever. And crash stands for the other findings. C is for conjunctival hyperemia, red, bloodshot eyes, but with no pus or discharge.
Or
R is for rash, a polymorphic rash, but not that ring-shaped one we see in RF. A is for adenopathy, which is swollen lymph nodes in the neck, usually on one side.
Yes.
S is for strawberry tongue and mucositis. So you see these really dry, cracked red lips and that classic red, bumpy strawberry tongue.
And H.
H is for hands and feet. You get redness and significant swelling of the hands and feet.
Okay, so that's a ton of inflammation. What happens when we move into phase 2, the subacute phase?
The subacute phase starts once the fever finally breaks, and it lasts until all the other clinical signs go away. And this is where you see the classic skin peeling.
Desquamation.
Desquamation. You get the significant peeling and cracking of the skin, especially on the tips of the fingers and the toes. When you see that peeling, you know you're in the subacute phase.
And this phase is when the risk for the most critical complication is highest.
Yes. The highest risk for developing coronary artery aneurysms is during the subacute phase, usually about 2 to 4 weeks into the illness.
So that's why cardiac monitoring is so vital then.
Absolutely. And it's why the antiplatelet therapy is so important. A red flag for the nurse here would be if the child starts complaining of chest pain. That could mean a myocardial infarction.
And finally, phase 3, the convalescent phase.
This is the recovery period. All the signs, the fever, the rash, the swelling, they're all gone. But the child isn't really out of the woods until their lab values, like their ESR and CRP, get back to normal. And that can take 6 to 8 weeks.
Is there a late finding parents might see?
Yes, bow lines. They're these little horizontal ridges or lines that appear across the fingernails, basically marking the time the body went through that severe systemic stress. They show up about 6 to 8 weeks later.
And what's a major teaching point for parents during this phase when the child seems better but isn't fully recovered?
You have to tell them that the child can remain extremely irritable. I mean, just fussy, hard to soothe, easily upset, for up to 2 months after the acute symptoms are gone. This prolonged irritability is a hallmark of KD recovery.
Okay, let's just create a quick mental filter to differentiate these. Focus on the skin and mouth findings because those are often the easiest clues in a question.
Okay, so use the location of the damage as your guide.
For RF, you're looking at the trunk and over the bones.
Right. RF gives you that erythema marginatum, the ring-shaped rash on the trunk, and the non-tender nodules over bony spots.
And for KD, you're looking at the hands, feet, and mouth.
Exactly. KD gives you the strawberry tongue, the cracked lips, the red palms and soles, and most importantly, That peeling the desquamation of the fingertips and toes. Peeling skin screams Kawasaki. Migratory joint pain screams RF.
To make this even clearer, the sources bring in a comparison to infective endocarditis, which is another condition that can get confused with these.
Yeah, this is a great check on your clinical reasoning. Infective endocarditis, or IE, is a bacterial infection on the heart valves, and its signs are totally different from RF and KD.
So what are the key findings for IE?
You need to remember two things. Oslo nodes, which are painful, tender, red bumps on the pads of the fingers or toes, and Janeway lesions, which are painless, hemorrhagic spots on the palms and soles.
So if a question describes painful bumps on the fingertips, you can immediately rule out RF and KD and rule in IE.
Exactly. It's a powerful differentiator. And that brings us right back to prophylaxis, doesn't it?
It does.
Because you have to remember that kids who already have valve damage from RHD are at super high risk for getting IE.
So the most important prevention strategy for them
Is getting prophylactic antibiotics before any kind of invasive dental procedure where bacteria could get into the bloodstream. That's a huge safety point.
It really is. The history and the physical findings, they absolutely determine your diagnosis and your next steps.
That's right.
Okay, let's move into management. The treatment plans for rheumatic fever and Kawasaki disease are just worlds apart, and this is probably the highest yield section for any exam.
Absolutely. The treatments are dictated completely by the underlying pathology.
Let's start with rheumatic fever.
Okay, for RF, you have two main goals. One, immediate eradication of any lingering strep, and two, long-term prevention of it ever coming back.
Let's talk eradication first.
To stop the autoimmune process in its tracks, you have to give penicillin right away. That can be a single shot of penicillin GIM or a 10-day course of oral penicillin V.
And if the child has a penicillin allergy?
Then the alternative is usually sulfa or erythromycin, also for a 10-day course. And the nurse's role here is all about ensuring compliance, making sure they finish that full 10-day course, even if they feel better.
But the real meat of the discussion for RF is that long-term prophylaxis.
This is a huge testable point. The prophylaxis plan depends entirely on one thing. Did the initial RF episode cause permanent heart damage? Did it cause RHD?
Okay, so what if there was no carditis, the heart was spared?
If the child had RF but their heart is okay, they still need continuous antibiotic prophylaxis for at least 5 years, or until they turn 18, whichever is longer.
And the goal there is to prevent another strep infection from starting the whole process over again.
Exactly. But now, what if there is RHD? If there's known damage to the heart valves?
What's the protocol then?
The sources are crystal clear on this. If there is valvular damage, the child needs lifelong antibiotic therapy.
Lifelong.
Lifelong is a massive, life-changing difference. And the reason is simple. Every single time they get another RF episode, the valves get more and more scarred. Lifelong prophylaxis is the only way to protect their heart function.
What about aspirin in rheumatic fever? What's its role?
In RF, aspirin is used just for its anti-inflammatory and antipyretic effects. It's really just to control the acute symptoms, especially the pain and swelling from the polyarthritis. We're not using it for its antiplatelet effect like we do in KD.
And activity. What should we tell parents?
During the acute phase, especially if the child has a fever or carditis, strict bed rest is recommended. You want to reduce the workload on the heart as much as possible.
And after they're better.
After they recover, or after any cardiac procedures, the nurse needs to teach the parents to avoid large group settings, like daycare, for about 4 to 6 weeks. You just want to minimize their exposure to any new infections.
Okay. Now let's shift to Kawasaki disease, where the management is so specific and so time-sensitive.
It absolutely is. Yeah. And the treatment has to be started within the first 10 days of the illness to really work well.
And the cornerstone therapy is a combination of two things.
It's high-dose intravenous immunoglobulin, or IVI, and high-dose aspirin.
Why that specific combo?
The IVG works to basically reset and calm down that chaotic immune response. It reduces the acute inflammation that's attacking the blood vessels, and that significantly lowers the risk of developing those coronary artery abnormalities.
Let's really focus on the aspirin protocol here, because I feel like this is a guaranteed NCLEX question, that dose switch.
It absolutely is. You have to remember the two distinct phases of aspirin therapy in KD. Phase 1 is the anti-inflammatory dose. This is a really high dose, 80 to 100 milligrams per kilogram per day. You use it at the beginning to get that severe fever and inflammation under control.
Then once the fever is gone for a couple of days, the dose changes completely.
It changes dramatically. That's phase 2, the maintenance or antiplatelet dose. The dose is lowered way down to an antiplatelet range. The goal now is no longer about inflammation. It's about preventing platelets from clumping together and forming clots inside those damaged or aneurysmal coronary arteries.
And that low dose is continued for a while.
Oh yeah, often for months, or at least until follow-up echocardiograms show that the coronary arteries look normal.
Okay, we have to talk about the Rey syndrome risk. We're giving a child a lot of aspirin.
This is a critical safety check. Aspirin is absolutely necessary for its antiplatelet effect in KD, but it comes with the risk of Rey syndrome if that child gets a viral illness.
So if the child is exposed to something like chicken pox or the flu,
The aspirin therapy has to be stopped immediately. You must discontinue it.
but they still need that antiplatelet effect, so what can be substituted?
The source material suggests that dipyridamole or persentine can be used as a substitute to maintain that antiplatelet function without the Rey syndrome risk during a viral infection.
Let's talk about nursing care during that acute phase when you're giving the IVI. What are the key assessments?
Well, IV is a blood product, so you have to monitor it just as carefully. You're watching for any signs of an allergic reaction: chills, fever, trouble breathing. You start the infusion very slowly and you stay with that child, especially for the first 30 minutes.
And beyond the infusion itself.
It's all about comfort. These kids are incredibly irritable and uncomfortable. So loose clothing, cool compresses, and a big focus on oral care. Because of those cracked lips and the strawberry tongue, they need clear liquids and soft, bland foods to keep them from having more pain.
And the long-term surveillance for that worst-case scenario.
You are constantly monitoring for coronary artery aneurysms. Even with treatment, it happens in about 5% of kids. So they will need regular echocardiograms all through the illness and recovery to visualize those coronary arteries and catch any damage early.
Okay, so since both of these conditions can lead to chronic heart problems, let's quickly review some of those high-yield cardiac drugs that might be used for something like heart failure. Let's start with digoxin.
Digoxin is a cardiac glycoside. Its main job is to make the heart muscle contract more forcefully. It's a positive inotrope. This increases cardiac output, which then helps decrease edema and, over time, can even decrease the size of an enlarged heart.
But the big challenge and the highest yield testing area for digoxin is all about safe administration and watching for toxicity.
Absolutely critical. It has such a narrow therapeutic range, which makes it very dangerous if it's dosed wrong.
So before you give any dose.
You must check the apical pulse for 1 full minute. And the rules are strict. You have to withhold the dose if the pulse is less than 90 to 110 for infants and young kids, or less than 70 for older children.
And there's a 2-nurse check required, right?
Yes, standard practice is that a second nurse needs to independently verify the dose before you give it. It's a crucial safety net.
And what are the signs of digoxin toxicity we need to teach parents to watch for?
The first signs are often GI related, so vomiting, nausea, loss of appetite. In older kids, you might see some CNS signs like a change in their pulse rate or rhythm, or even visual changes. They might say they see halos around lights or start rubbing their eyes a lot.
Okay, classic nursing question. The child takes the dose and immediately vomits. What you do?
You do not repeat the dose, ever. You have no idea how much they absorbed, and giving another full dose could push them into toxicity. You just document the vomiting and call the provider.
We also have to hit on that dangerous interaction between digoxin and diuretics like furosemide.
This connection is so important. Lasix is great for getting rid of fluid and heart failure, but it also makes you lose potassium. And hypokalemia low potassium makes the heart muscle much more sensitive to digoxin.
So low potassium increases the risk of digoxin toxicity even at a normal dose.
Exactly. It's a classic NCLEX trap. So if your patient is on both digoxin and Lasix, you have to be aggressive about their diet.
Meaning you need to supplement with potassium-rich foods.
Right. You need to teach parents about bananas, oranges, potatoes, leafy green vegetables, all of those things.
And finally, what's the other major drug class used for heart failure that's mentioned in the sources?
That would be the ACE inhibitors, angiotensin-converting enzyme inhibitors. Captopril is a common one. They're vasodilators. They basically lower the pressure the heart has to pump against, making its job easier.
This has been an incredibly detailed review. Before we wrap this up, let's do one final summary. The key differentiators you absolutely have to take into an exam.
Okay. When you see a question, your first thought for rheumatic fever should be, this is a consequence of untreated strep. It uses molecular mimicry to attack the valves, which can lead to RHD and require lifelong penicillin prophylaxis. You confirm it with the Jones criteria.
Perfect. And for Kawasaki?
Or Kawasaki, you think. This is a systemic vasculitis that attacks the coronary arteries. The risk is aneurysm. The treatment is time-sensitive. IVIG, and a 2-phase aspirin protocol. And you always have to be watching for that Rey syndrome risk with viral illnesses.
So understanding that structural target valves versus vessels is really the most efficient way to keep the management straight.
That's the clinical reasoning that gets you the right answer. Linking the pathology directly to the intervention. That's true nursing skill, not just memorization.
And that leads us right into our final provocative thought. Let's zoom out from the bedside for a moment. We've established that RHD is almost entirely preventable with prompt antibiotic treatment.
And we know that KD and MISC could potentially be prevented if we could stop those post-infectious immune reactions from happening in the first place.
So think about the massive cost of these diseases. The lifelong appointments, the potential for multiple surgeries, the medication burdens.
It's a huge burden on the patient, the family, and the healthcare system.
So if our real goal is to mitigate all of that, what kind of systems-level changes would we need? I mean, beyond just the school nurse screening for strep throat, should there be huge public health campaigns to make sure every single sore throat in an underserved community gets tested?
Could we develop advanced vaccines against the common viruses that seem to trigger conditions like KD and MISC? The highest level of care isn't just treating the disease, it's preventing it from ever getting a foothold.
Exactly. Thinking about prevention on a community and public health level really is the next frontier, something for you to think about until our next deep dive.